Welcome, everybody, to the Gladden Longevity Podcast. I'm your host, Dr. Jeffrey Gladden, and this is a podcast that's really devoted to helping you live young for a lifetime. And what we mean by that is having a 30-year-old body when you're 100 and a 300-year-old mind. In order to get there, we're really dedicated to answering four questions. How good can we be? How do we make 100 the new 30? How do we live well beyond 120? And how do we live young for a lifetime? And those questions empower all of our thoughts, actions, explorations, and it's really, really powerful to wake up young every day. I wake up 27 every day. I would encourage you to wake up young every day. And I love being on this journey to developing this 300-year-old mind, all the wisdom, equanimity, insight, and discernment that comes from that. Today, I had the opportunity to jump into a conversation with Mariza Snyder, and she is basically working with women around perimenopause. And I think you're going to find this conversation fascinating because we've been thinking about hormone replacement therapy as something that comes up for people as they go through menopause. She's talking about hormone replacement therapy prior to menopause and perimenopause, and actually even prior to that in pre-perimenopause. I think you're going to find this conversation really fascinating. We go down many different pathways. And in the Age Hackers portion, we go even deeper on a number of things related to sexual function and relationships and many things that I think you're going to find extremely interesting. This was a really fun conversation. I hope you enjoyed it as much as I did.
This episode of the Gladden Longevity Podcast is brought to you by Mimeo, a supplement designed to give people the benefits of fasting without having to fast.
Yeah, Mimeo's research found that the human body produces a unique set of molecules during a 36-hour fast. And those molecules were responsible for activating many of the cellular health and longevity benefits of fasting.
With Mimeo, you can get the cellular health and metabolic benefits of a 36-hour fast even during a meal, or you can use it to maximize the benefits of your shorter fasts with powerful boosts in mood, focus, energy, performance, recovery, and appetite control. Dr. Gladden, in the 2 years I've been working with you and the 5+ years I've been listening to the show, I've never heard you talk about something outside the Gladden Longevity line of products like I've heard you talk about Mimeo. Why do you like it so much? Use it and make it a part of some of your presentations.
Yeah, we love it, quite honestly. I mean, the idea of Mimeo being able to mimic fasting, we all know the benefits of fasting is dramatic in and of itself. And even in the context of if you're eating, and if you're fasting, it even augments your fast that much more. But the interesting thing is that it also decreases things like neuroinflammation, it suppresses appetite, and it increases a very, very important biological process called reverse cholesterol transport. And that's critical for cardiovascular disease, for decreasing risk of dementia, cancer, etc. It's really, it's quite a fascinating product. I've really been kind of blown away by it.
As a way to help support this podcast and save money on your Mimeo order, you can use the discount code GLADDEN10 to get 10% off your order at mimeohealth.com. That's that code again, mimeohealth.com. That code again, GLADDEN10 at MIMIOhealth.com.
Think of it as a way to unlock the power of your biology. Welcome, everybody, to this edition of the Gladden Longevity Podcast. I'm your host, Dr. Jeffrey Gladden, and it's a beautiful day here in Texas. I'm really back on a push to build my cardio. My cardio was really great about 6-8 weeks ago, and then I got into a routine where I got separated from being able to do as much as I wanted to in a week. So I'm back on track and feeling good, riding the mountain bike again. I find if I can ride the mountain bike 2 to 3 times a week, my cardio just goes through the roof. Like I can hit gears that I can't get otherwise. And so I'm super excited about that. We've got good weather here. And I'm going to do this podcast, but well, I'm glad to be doing this podcast. I was going to say I'd rather be out on the bike, but that's not true. I'd rather be here with our guests. So
it can be a yes and.
It can be a yes and. There it is. So maybe we should do this podcast on a mountain
bikes next time.
That's it. So I'm joined today by Mariza Snyder, and I've told you a little about her in the intro. But Mariza, welcome to the Gladden Longevity Podcast.
Thank you so much for having me.
Yeah. So we were talking for a minute before we started recording, and you were talking about a conjunction of a couple things in your life. One having a toddler, and the other one being perimenopause.
Yeah.
Perimenopausal. So that's an interesting combination.
I think so.
Yeah, right. It sounds fun to me. So to bring us up to speed, how did you get interested in this whole area of perimenopause? And just walk us through that a little bit.
So the first kind of experience I had with perimenopause was my mom's experience, and it was a nightmare unfolding in front of my eyes. My mom just dealt with every symptom you could imagine, but most importantly, she and probably 85% of women experience severe mood changes, perimenopausal rage. She found herself, I remember her going to her OBGYN and saying, hey, is it normal for me to want to kill somebody for 5 days out of the month? And they were like, yeah. Mm-hmm. And, but no solutions.
Right. That's where gun legislation comes in.
Right. Exactly. Right. And so I watched my mom really struggle. And at some point she was put on Premarin to, didn't test her hormones, anything like that. And honestly, she was more estrogen dominant at the time, probably in her early to mid 40s, than she was depleted. And it just sent her into a kind of worse spiral. And so I was
let me back up on your mom, just so the audience has a bit of a running start. So your mom, was obviously a woman. She apparently got married or had a partner. And how many kids did she end up having?
Yeah. So my mom got pregnant. Shotgun wedding. My mom got pregnant on accident with me when she was 18 years old. And was kind of forced into, keeping me and getting married to my dad. And so I was a single mom by the time I was 3.5 years old. So a lot of stress, a lot of survival mechanisms. It was a very stressful life for my mom. And so, she had period issues. I really do think she had PMDD for most of her adult life. And so not diagnosed.
Explain that acronym for the audience.
Absolutely. So it's a more severe version of PMS, where it is predominantly more mood swings, more anxiety, more depression, more inflammation during the kind of the luteal phase, the second part of the menstrual cycle. And we don't really have still to this day, don't have a lot of solutions for women. And often it's still misdiagnosed. And so my mom really had a hard time. So heading into perimenopause, not really addressing any of the, reproductive menstrual cycle issues she had for, I don't know, a good solid 2 decades, maybe more. Heading into perimenopause, her symptoms just kind of exacerbated.
Okay. So let me interrupt you there for a second. So what age was she when she actually started to go into perimenopause?
I would say that, because I'm, again, from a standpoint of me, we haven't, I know when she went into menopause, I obviously knew by the time she was having pretty severe symptoms, and I find that this is the case for most women, it's usually in the late stage of peri. So the average age of symptoms for women in perimenopause usually start between the ages of 40 and 44. My mom was probably 45. And it can vary. So natural menopause. So the average age of menopause is 51.5 years. But natural menopause can happen anywhere between 45 and 55 years old. And then the transition, that is perimenopause, right? That the fluctuating, declining hormones, the decline of ovarian function, the remodeling of the brain, all of that happens in a span of, let's say, 7 to 10 plus years leading into menopause. And so for my mom, who went into menopause, I want to say around 53 years old, probably started around her, I would say 42, 43. And then symptoms kind of increased as she got into her mid to late 40s.
So she had pretty rough cycles to begin with. It sounds like, right? A lot of mood changes. It sounds like maybe cramping and some of the other symptoms that go along with it as well. Or was it mostly? Yeah,
her most severe symptoms during her cycling years were the intense mood changes. The severe anxiety, the rage. She had all of that. I mean, obviously a kind of a more subdued version of that before perimenopause. And then it really shifted. Yeah, really amped up. I was going to say really ratcheted up in perimenopause.
Right. So, these sound to me, and obviously I'm male and not female, but it sounds to me more like the estrogen dominance
Yes.
kind of symptoms that people experience, right? And in a woman's cycle, they become estrogen dominant towards the end of their cycle in that premenstrual phase, right?
Yeah,
And
if progesterone isn't there robust enough. And, my mom, I remember growing up, my mom would tell me, the women in your family, us, we don't make progesterone. And potentially she may have been correct. I remember when she first, when you start to experience symptoms, I find that estrogen dominance comes online kind of, the early signs of that for most of the patients and women I'm working with will be early, I would say mid to late 30s is when they'll start to see that shift. Because that's when progesterone, if you don't have a robust ovulatory cycle, you're just not going to see robust progesterone levels. And that's kind of where we tip the scale. And so for my mom, I remember in her mid 30s, she tested for progesterone and she was in menopausal levels. And so she made this assumption that we just don't make it. And we all often range towards more estrogenic. And I think a lot of that has to do with, I don't know if it's epigenetics, I don't know if it's generational trauma, or I don't know if it's real-time trauma. But I know that due to an overreactive stress response system that has had a profound impact, at least in the women in my family's reproductive system and ovulatory process, that led to declining progesterone levels earlier than maybe most. But that's very much what happens to women in perimenopause anyway, whether you have trauma or not.
Let me interrupt you for a second here, because this is really interesting what you're saying. So for the audience listening, you can really start to feel some of these symptoms really in your late 20s, early 30s, when things are starting to shift around how much progesterone you're making. I think it's important to understand that, because you're not actually technically sort of perimenopausal, but you're actually sort of pre-perimenopausal, right? You're pre, right? And that's an interesting thing. In genetic testing that we do, we can see genetically people that are more prone to stress, people that are more prone to vigilance, anxiety, things like that. We see some of that in the genetics. What I really haven't seen in the genetics, though, is, and we do see how people process testosterone to estrogen and some of the pathways with regards to estrogen metabolism, if you will. But I haven't really seen, and maybe you have, is kind of the inherent question here, genetics that kind of point towards how much progesterone someone is likely to make. I haven't seen that, I don't think. I
haven't seen the genetics either. I really just do feel like it's more the environmental cues of how our women, I find women as the bearers of children, and I don't know if you've seen this in the genetic profiling that you've looked at, but there's more of a tendency towards survival, like maintaining survival. And so I find that we tip the scale with stress a little bit easier, or it has a more profound impact on our reproductive system and our menstrual cycle. And I do see it having an impact on, the robustness of ovulation. And I think based on that, then we'll see that trickle down of progesterone. I don't believe that there's a progesterone steal. I think ultimately it's just, if our system is more vigilant for whatever reason, it has an impact on our reproductive system. And that makes sense for a lot of other animals as well, from what I can see.
Yeah, I think that's right. I mean, I think, I think the females caring for the children, if you will, kind of historically, and to some extent to this day still, there is a need for vigilance, right? It's like you look at
protector energy.
Exactly. You look at a lioness, or you look at a female chimpanzee or whomever else, right? They have that very protective, vigilant kind of quality about their psyche. And it's
I have it for sure.
Okay, so you have a toddler also.
I have a little boy, and I am fierce about my son.
Well, there it is. It's mama bear.
It's mama bear energy,
right?
For sure.
So what you're saying is that this mama bear energy may be interfacing with, and I think there probably are some underlying genetics that we haven't outlined here just yet, but some predisposition towards anxiety and stress response and carrying that hypervigilance, but also intersecting with probably some susceptibility to how much progesterone somebody's likely to make genetically and whether it goes lower, and being sensitive to the estrogen too, right? So, you also have people with PCOS in this,
Yes.
polycystic ovarian syndrome, right? And so they can be estrogen dominant. They can have higher testosterone levels and higher insulin levels and glucose levels and things that we now understand about PCOS. And I think those people also struggle with rougher premenstrual symptoms, if I'm not mistaken, right?
That's absolutely correct. Yeah, I find that there's a big, not in all cases, probably 85% of the cases of polycystic ovarian syndrome that I've worked with, there's a big metabolic component. There's often, that underlying insulin resistance that is always on my radar that I'm looking at.
That's right.
And it's no surprise, if we've got a metabolic issue, it's going to impact our reproductive system.
Yeah. So then the question becomes, so this is happening, and, in the training that I've done around women's hormones, progesterone becomes kind of the magic bullet for a lot of people in terms of if you can elevate the progesterone, you can kind of reestablish some sense of calmness in the system, so to speak. You can counterbalance the estrogen. You can also sort of calm down the central nervous system to some extent. And it doesn't work for everybody, but it certainly doesn't work for everybody. But oral progesterone, which gets metabolized through the liver, can spin out some metabolites that can have sort of a soothing, calming effect on the system. Do you want to speak to that? What your experience is with that? How effective or?
Yeah, I'm taking Prometrium. I can absolutely speak to it. Just like my mom, I had flatlined progesterone levels in my mid-30s. I mean, she was right in some regard. She didn't understand why. In her blanket statement, but it was very true for me too. And even, progesterone is it's a mama hormone in its own right, but it does calm and soothe. It helps with sleep, anxiousness, but ultimately progesterone is for procreation. And so when I was trying to get pregnant at 40 years old, I ended up getting, pregnant at 40. I miscarried the first time. We thought that maybe I had enough progesterone to carry through, and I didn't. And so,
So that's a good point. Just so the audience understands, you need to have progesterone. What does progesterone do after someone's impregnated? Well, it basically keeps the endometrial lining thick and sort of lush with blood flow and the things that you need to support a pregnancy. And so, part of infertility or difficulty carrying a baby, I mean, there are many different elements to it, but one is if you don't have adequate progesterone, you'll just never have enough endometrial support and uterine support to actually carry the pregnancy through. So in your case, that happened once, and then you started on progesterone.
I did. And I maintained it until I think into the second trimester. But then, after I had my son and, a couple years after postpartum, it was very clear that I was smack dab in the middle of perimenopause. And sure enough, it's fascinating. I'm very curious to look at the research, which doesn't really exist yet, but women who do wait later to have children in early peri, and how it seems that many of us get kind of drop kicked into perimenopause.
Into menopause itself.
Yes,
Right. So let me ask you this. What were your symptoms? Were they similar to your mom? Was it a kind of a rage and I'm going to go get a gun or?
No, yeah. And the first symptom was brain fog for me. And at the time, a couple things in conjunction. I breastfed my son until he was 2.5 years old. So I was well into 40, almost 44 years old by the time I finished that journey. But we're actually, and I hope it's not too noisy, but we're in the middle of a mold remediation. And so I got hit with mold last year. So it's a confluence of things. For me, I find what it's interesting about perimenopause is that I rarely meet women who don't have other things happening at the same exact time, other health conditions. And I do find that the shift and decline of these very critical hormones can really bring other health issues up for review. And so for me, I was coming out of postpartum, finishing my breastfeeding journey. We've got mold in the house and my hormones are declining. Right. And so, the first sign for me, the first symptom was brain fog. Second symptom where I really knew it was classic peri, just based on my mother's symptoms and so many of the things that I'd seen in my own patients, was the mood swings. That was very textbook perimenopause.
That can feel like it's completely outside of your control. I know this on the male side of it from the standpoint of going without testosterone. and then getting too much testosterone, and then finding sort of the happy medium. And it was remarkable to me how, we sort of think we're in control of who we are, but when there's too much testosterone there, it's like
you're a different person.
Yeah, you're a different person. You're on edge. You're a little, more aggressive. You're whatever you are. When you're depleted, you're a different person too. It's like you're depressed. You're tired. There's just no interest in much of anything. And it's fascinating how much these hormones dictate our sense of well-being as well as our behavior, quite honestly.
Agreed. Well, and what's even more fascinating, and the research is becoming more clear, is that this perimenopausal transition is one of the 3 times that women's brains remodel in a massive way. The first time is puberty. Girls' brains completely remodel as what I call they're coming online to reproductive, ovarian function. And then the second time is going to be pregnancy postpartum, where I probably the biggest remodel of them all. Because gosh, you become a mom and you are not who you were.
Yeah,
You'll never be who you were again.
That's right.
And then the third time is perimenopause. And we're very fascinated with that because when women come on the other side of peri into menopause, all of a sudden their risk factors for cardiometabolic disease, for dementia, it all increases, greatly. And so we're interested in knowing what is happening where these critical hormones that have receptor sites or even being made in the brain, progesterone being one of them, like allopregnanolone, when we start to not have these hormones binding to the receptor sites in our brain, and then a remodel happens, what does that do to us as we move into kind of the third part of our life?
Well, there's some really strong data around that as to what happens. There was a huge study out of Kaiser Permanente that maybe you've seen. It was published some years ago now, maybe 3 or 4 years ago, and they looked at 500,000 women that were in Kaiser, and they basically divided them into 2 groups. One that received no form of hormone replacement therapy, and those that did receive any form of hormone replacement therapy. And it was interesting because it could have been unopposed estrogen, it could have been just progesterone, it could have been testosterone, it could have been a suite of estrogen, progesterone, testosterone, and even some DHEA, whatever it was. And what they found was that even the women that were on hormone replacement therapy for any length of time, whether it was like 4 months, a year, whatever, when you compared those 2 groups, there was like a 50% reduction in the amount of dementia that occurred. And it was really quite stunning. When you talk about remodeling of the brain, have you done some work in that area to kind of understand those remodeling, what actually happens kind of neurologically for people, or is that a little outside the scope?
It's a little out of my scope. It's such infant. I would say that the research is so brand new. Who I'm following is Dr. Lisa Mosconi, who's doing a lot of the brain scans on women in menopause specifically, and looking at her research and just seeing the changes that happen in perimenopause, how our brains look on the other side of menopause, and how is that lending to things like dementia and Alzheimer's.
Yeah, it's really fascinating. I think, men go through andropause, women go through menopause, and they are different, but it's a stunning shift for women. Everything from metabolic health to bone density to muscle mass to how they think about themselves, to their ability
insulin
to
resistance.
Insulin
neuroinflammation.
Right.
All of it. It's a profound shift. And so I'm a big advocate of hormone replacement therapy and really hormone replacement supplementation in perimenopause. I don't think we should be waiting until women are ground zero with their hormones to start replacing them.
So that's a really good point. I think a lot of people still have this, and certainly in the traditional OBGYN community, there's this mindset about waiting until somebody has symptoms of something, and then we'll give them just enough of something to kind of decrease the symptoms, whether it's dryness or hot flashes or whatever it might be,
osteoporosis or whatever. Yeah,
right. But there's no real sense in that community of optimizing hormones in a way that actually promotes a more youthful, expression of who that person is, right? So that is interesting. And what you're saying is even more interesting because a lot of people still feel like they need to wait until they're kind of menopausal or very close to menopause, right, before they would think about hormone replacement. But I think it's interesting that you're advocating, and we've done this for clients as well, where you can start, years ahead of when menopause might occur, kind of calming the system with some progesterone, or, giving them something else, right? Some pregnenolone or whatever you think it might be helpful. So do you want to talk about that a little bit, how that view has shifted for you? Yeah.
Yeah, absolutely. I mean, ultimately, just managing symptoms is not good enough, not for our longevity and not for our health span.
Sure.
And I will say that hormones are optimizers. And when we were talking about dementia, if we had a silver bullet, estradiol is going to be it for women specifically. But yeah, when women start to experience symptoms, again, it's very clear that we know that progesterone is going to be the first hormone to drop. And what women will experience due to that is, more anxiousness, more, that perimenopausal rage, maybe that estrogen dominance, profile, where heavy periods, bloating, migraines, those types of things will start to show up, or sleep issues. And so I think the first step is always bringing in 100 milligrams to 200 milligrams of micronized, oral progesterone. I think that's a great place. And then when women start to, and I think, the question people always want to know, well, can you test for perimenopause? And it's kind of the same thing around women in puberty, girls in puberty. Like, if we know she's 14 and she has a period and her body's changing, well, she's in puberty. Like, we don't necessarily need to test for that. But we absolutely, there are testing that we can be looking at for women in perimenopause to really optimize their health span. But would I recommend Prometrium or a type of progesterone for women who have symptoms and I don't necessarily need to look at those levels? Sure. But then if I start to see other shifts and changes in the Prometrium, it just isn't cutting it. That's when I would like to bring in a little bit of estradiol to kind of help. And that's where I'm at, when Prometrium, it's doing its job, but I'm noticing other things. I have other symptoms. And, again, in perimenopause, these hormones are so erratic. They can change by the day. They can change by the week. Right. So it can be hard to nail exactly what is going on. But I don't think there's any harm at all in bringing in these hormones, especially as women start to experience the early signs and symptoms of peri, because it is because of these hormones, not binding to these receptor sites. So I'm all for being on all of it.
Right. It's a little bit of a classic case of treating the individual instead of the test results or the lab results, right?
I think that there's a fine-tuned difference too. Like, you can look, I believe in both. I think it's individual.
Me too. Yeah. So I'm curious about the testing that you do. So if people are listening to this and they're wondering, well, gosh, maybe I'm starting to feel something, what test should I get done? What are you currently recommending? I know what we do, but what are you thinking about?
Yeah. So we're looking at the full comprehensive. So if I had my way, and I could look at testing. One, I want a timeline over time. In my ideal scenario, I'd love for women to start testing in their 30s so that I could see things over time, so that I have a good sense of who you are and what changes for you over that continuum of the decades.
And what point in the cycle do you want to test them?
I personally, I'm a big fan of looking at, I'm looking metabolites, estrogen metabolism, progesterone, estradiol, and, estrone, and also looking at testosterone, DHEA. So I typically look 7 days prior to a woman's period. So usually if they're a 28-day cycle, around day 20, day 21, that's when I'm looking.
So I wanted you to bring that out because this is how we feel also for people that are still menstruating. And I think it's important, if you're listening to this, to make sure that you time if you're going to do this sequentially over time, let's say you're going to test it every 6 months or whatever it is, when you're in your 30s, I think it's important to do it at the same time. Otherwise, you can't really compare the results. So just know that if you're going to do it on day 21, then do it on day 21, as best you can.
Yes, be consistent.
So,
yeah, and track your period. Like, especially if you're if you're cycling, or you're in perimenopause, you still have a cycle. Track your cycle. Know your cycle. Because mine's changing. It's meant to. What was a 28-day cycle is now a 26-day cycle, and so I'm usually testing on day 19 for myself.
Okay, there is some interesting data out of Harvard. I was at a conference and heard a woman that's a PhD doing some research up there. She's not a physician, not a practicing individual, but she, I believe, had a family history of early menopause, and noticed that there's a correlation between the time of menopause onset and an individual's longevity. And the idea is that the ovaries have a life cycle that's about equal to half of the lifespan. So the idea was, okay, well, what if we could develop a molecule that would actually enable ovaries to continue to function longer? Would that have an impact on overall longevity? And really what you're doing is you're kind of coaxing the system not to go into menopause or perimenopause. Right. And I think we're still probably 2 or 3 years away from them, running through their FDA process to get this approved. But it is an interesting thing about what people can do to push off menopause or perimenopause. Do you want to talk about that a little bit? Because there are certainly things I think that will precipitate it quicker. I think high stress, pregnancies, deliveries, some of these things. Do you counsel people around other things to kind of mitigate it in any way? Or do you have any tools like that?
I would say, my best tools are really going to be lifestyle tools. I think hormones as well. Hormone replacement, hormone supplementation, I think is a game changer. I'm really interested in women's, particularly their metabolic health, their inflammatory markers. I really want to be looking at all of those arenas to make sure that they're really optimized. I'm looking at their nutrient profiles, with their vitamin D levels, their B levels. I just want to make sure that they're within optimal ranges. Tracking blood sugar, I'm tracking fasting insulin. To me, those seem to be the biggest levers that women can pull for extending longevity.
Yeah, interesting. Yeah, very interesting. So tell the people a little bit about where you're located, what you're.
Yeah, I'm in Encinitas, California, right at the beach. And, for the most part, a big part of my work, I develop programs, I coach patients through mainly the midlife metabolic journey. That's a big area that I love to focus on, is how can I optimize women's metabolic health, their strength, their power. I think that most of us imagine ourselves in our 60s and 70s being strong and resilient. And so how do we cultivate that? How do we optimize our zone 2 cardio? How do we make sure that we are maintaining our strength and muscle mass and our bone health? And really, doing our best to reverse any level of insulin resistance that we're dealing with. So those are the areas. I also look at, managing stress appropriately. So I often have women wearing a Whoop strap or an Oura ring. I usually put continuous glucose monitors on people because I really want them to see in real time what their lifestyle is, kind of, how it's manifesting in their day-to-day numbers.
Yeah. No, that's good stuff. One of the things that always comes up in conversations around hormone replacement is cancer risk, and trying to identify who might be at risk, and how you monitor people to see if there's any issues that are developing. Do you have any sort of protocols that you utilize or
I think
along that?
Absolutely. I think, I'm always thinking about our liver and our gut, our microbiome, but particularly how we're metabolizing our hormones. And so I think anytime if a woman's on birth control or hormone replacement, or they're naturally cycling and making their own hormones, that we are using them and losing them, that we're properly metabolizing them. And so I am always very interested in making sure that their gut microbiome's healthy, their beta-glucuronidase is in check, that their liver detox pathways, intermediate pathways are open and functioning. And so usually with supplementation is what I'm using to help women in supporting their metabolism of hormones.
Right. So she just mentioned the term beta-glucuronidase, which is something that's made by E. coli in the gut. And it's an interesting molecule because when you're trying to detox, you have to understand that when you're metabolizing your hormones, they're actually being metabolized through your detox pathways, the same way that you would get rid of a carcinogen or some other toxin that came into your system. It's true for men and women. They both go through these pathways. And there are genetics that determine how efficiently they move through those pathways and which forks in the road they take. And those forks in the road can have an impact on cancer risk or mitigating cancer risk. And it's really important to get those mapped out. We like using a Dutch test to get a handle on that. And
Yeah, when I was talking about optimal testing, Dutch testing is what I'll always use if I get to do so, along with all the other blood labs that I want.
Exactly. Okay. So when you're going along, I think it's important also from our perspective, if we're going to start HRT, we actually screen everybody for cancer, right? Does somebody have preclinical cancer? People can do routine sort of cancer testing, if you will, routine cancer markers. And some people are doing breast MRIs or ultrasounds. Some people are still doing mammograms, doing endometrial ultrasound or, pap smears
or these
or
pap
whatever.
smears. That's
Right.
what I did before I got on hormones.
Right. So doing those things is important. We've kind of have upped the ante a little bit further. Now we're using testing that enables us to look for circulating tumor cells. And there's a new test we're getting a hold of that's actually allowing us to see how the immune system is adapting in the presence of cancer, even if we can't not only see it on a scan, but we can't even detect it in the blood yet. So we're very excited about that because I think when we do see somebody that has cancer cells, then we take a different tact. It doesn't mean that we might not use hormone therapy, but we're going to be much more cautious. Just like in a man with that we're putting on testosterone therapy, we want to know, do they have any prostate cancer cells? And so we're looking at exosome tests, we're looking at circulating tumor cells, we're looking at MRIs of the prostate. We want to make sure that somebody is safe as they go forward on this journey, right? So I think as you're listening to this, just realize it's important that hormones can be great, but you also want to use them in a safe way too, right? So
yeah, agreed. And I know for the average person, women can get thermography, they can get ultrasounds, they can get mammograms, they can get pap smears. Like these are often covered by your insurance. And obviously there is further testing that you can do. In my journey, just recently, before I was getting on estradiol, we felt really good about me being on progesterone, but I decided, you know what, let's just run all the preventative, look at the pap smear, look at the mammogram and ultrasound. And there was abnormal cell activity. And so I'm still recovering from a breast biopsy. But I was clear, it was benign. But, and this was, it was important. It was due to the fact that I wanted to get on, an estradiol patch or a transdermal estradiol that I decided, it was just time for me to just re-up on all of these things. And sure enough, I ended up going down this rabbit hole. So.
No, it's a good rabbit hole to go down. And I think there are so many positives to hormone replacement therapy, brain function, bone function, muscle function, libido, stress resistance,
cardiovascular, endothelial function.
Cardiovascular, endothelial, exactly. Hey, you're talking to a cardiologist. So all that stuff, right? I mean, it's all super good. You just want to realize that you want to avoid the downside too, if there's anything there. So, so just go into it with your eyes wide open is what I would suggest if you're listening to this. Make sure that you know it's safe for you to start them, and then the general theory is to start sort of slow and kind of ease hormones into your system. It's not something where you want to slam somebody from 0 to 100 in terms of testosterone or estrogen or progesterone. It can be a shock to the system, and they can end up with certain side effects they don't want to have. So, but it's really
you can't go wrong in starting slow, especially again if you're starting in the transitional period of perimenopause, where you still making it. You're still your ovaries are still cranking those hormones out, and so that to me, I feel like it's such a great starting place for women because they can really kind of fine tune and test what that is like for them as they head into that menopause experience.
Yeah, no, I think that's a great point. I was just looking at some stuff where it appears that hormone replacement therapy doesn't really delay menopause. But the other thing is it doesn't seem to accelerate menopause either. So if if you want to use some progesterone, it's not like you're accelerating your way into menopause per se. So that's interesting also. Cool. Good. All right. Well, interesting conversation. Any other points that you'd like to bring forward for the audience here?
No, I was going to say, I know that you probably run your people through a lot of labs. I would say the other thing that I always want women to be looking out for, besides, their metabolic hormones, is looking at their thyroid panel, being mindful, looking at their inflammatory markers like, C-reactive protein, homocysteine, SED rate. One of the areas that I'm really focused on, just like you, is keeping my women, metabolically and cardiovascularly strong. That's really my intention.
Sure.
Women die more of stroke and ischemic attack than men do. It's just
Yeah, no, this is a great point, because women are protected while they're menstruating. I
Yes.
mean, men have higher rates of cardiovascular events,
earlier.
and
Yeah.
women are protected, but women actually really catch up when they go through menopause. So they catch up very quickly. And everybody worries about breast cancer, but 8 times more people die of cardiovascular events than breast cancer. So really the number one thing is what she's talking about here, what Mariza is talking about, which is cardiometabolic health is really like your prime focus. And then, of course, nobody wants to have cancer either. But it's just really important to understand that if you have a family history of heart disease, which is very, very common, of course, or a stroke or that kind of thing, that you should think about hormone replacement to protect you. I will say there's one caveat here, and that is that if you have a tendency for your blood to clot,
You have to be
then
mindful.
estrogen, particularly oral estrogen, can precipitate a higher incidence of clotting. So just realize that with this hormones, you've got to work with somebody that's knowledgeable enough to help you dance around the issues that you might have. And if you find somebody knowledgeable that can dance that dance, then you can do very well. But otherwise, it cannot work to your advantage.
Yeah, I think you need to be looking at all of those markers, especially if there's a history. There's a great history of heart disease in my family. My sister, who's younger than me, had 2 strokes last year. And for other lifestyle reasons that we won't get into. But, when I had my son, and one of the things also for women is paying attention to your pregnancy experience, your pregnancy journey. It's kind of a litmus test for us.
Tell me about that. Tell me how that.
So if women have gestational diabetes, we have a greater chance of diabetes down the road. If women experience preeclampsia or high blood pressure, again, there's a greater chance for that down the road. And so for me, I ended up getting induced a week early because I was heading into some pretty serious symptoms of preeclampsia. And so I knew immediately, often we're not told this, but I just knew that I was like, okay, this is going to be something, not that I didn't already know to pay attention to, but that this was going to be something I really needed to tend to in for the rest of my life. If I was triggering this in pregnancy at 40, then I needed to really pay close attention to this as I moved into my 50s, 60s and beyond.
Yeah, that's a really good point. I think a lot of people can be dismissive of in conversations I've had with people, many people will kind of bring forward things in kind of a dismissive way. Yeah, I was a bit diabetic while I was pregnant, or I had a bit of hypertension while I was pregnant. When a savvy practitioner hears that is a big red flag.
Yeah.
Because whatever happened then, you're going to be much more predisposed to later, whether it's insulin resistance, diabetes, hypertension, whatever it is. And so if you're listening to this, you should think about your own pregnancy history and across the pregnancies, if you've had more than one. And were there any issues that came up? Because those are going to be your easy targets to go after. And part of it will be hormone replacement, but a lot of it will be lifestyle. And a lot of it could be some other things too, right? Different supplements or medications to help manage. So pay close attention to that for sure.
Yeah, close attention. And then at that point in time, depending on, especially if you're older, maybe you're in your 30s or your 40s, my recommendation is get your labs ran every year. Get your fasting insulin, hemoglobin A1C, fasting glucose. For me, I have my SED rate ran every year, homocysteine, C-reactive protein, ApoB, triglycerides. I'm just looking at everything. I want to make sure that I'm keeping all of those levels in optimal range and functional range, not the range at your doctor's office.
I'll tell you one thing that we do that we've been doing for over a decade now, which is to do on every new patient is to do a 2-hour glucose tolerance test with an insulin curve. Because we've been stunned that people will come in with hemoglobin A1Cs that are really great, like 5.1. Their fasting blood sugar is 89. Everything looks great. Even their fasting insulin levels like 2 or 3 or something like that. All very, very good numbers. You challenge them with 75 grams of glucose. Oh my gosh. Some people handle that beautifully. Other people, your insulin level should go up maybe 4 to 5 times over baseline. So let's say you're at 3, should go to 15. These people will shoot up to 60 and their blood sugar will jump to 180, right? And so it's important to understand that genetically, and I'm one of these people, I don't get the signals that glucose has hit my system as it's coming in. So I'm slow. My incretin system is slow to get that signal into my pancreas. Consequently, I can shoot my blood sugar up, and then my insulin comes out and hammers it on the back end. So I'll go from 89 to 165 and then down to 50 at 2 hours, right? So it can be such a revealing test. So if you've had any kind of issue with carrying extra weight or any kind of insulin resistance during a pregnancy or anything, I think actually getting a 2-hour glucose test with an insulin curve so you can actually see what's happening is so enlightening. Because I found that we can be fooled just by hemoglobin A1Cs and fasting blood sugars, right? So
I agree. Yeah. That's why at least I always want a fasting insulin before. And then if I start to see, and I'll put again, continuous glucose monitor on as well. But if I see trending that doesn't make sense, then I will order the more advanced testing to see what's going on.
Mm-hmm. Beautiful. Yeah, good. Well, it's a fascinating area. I appreciate you taking the time to chat with us about it. I think what's interesting to me is that we're moving into being more preemptive in this area. Instead of waiting for symptoms and then starting HRT, even if you're going to do bioidentical HRT, kind of waiting for menopause, it's this idea of, no, let's actually manage this person, their personality, their life experience, if you will, with the hormones appropriately as they go through these, pre and perimenopausal periods. So cool.
we're getting better at doing better. That's for sure. Mm-hmm. And I do, based on the research that we're seeing is that, this transition period, I think to me is very critical. And once we get to menopause, a lot of things have already changed and shifted. It just is a bigger uphill battle. And so if we can catch you in this kind of this transitional period where everything's in flux, and for some women, it just feels like pure chaos, we can just do better at managing women in this particular, in this transitional period.
Yep. I will say too, and this for a fact, that some women are very, very sensitive to hormones and others are quite a bit less sensitive. Like you can put them on some estrogen, progesterone, maybe a little DHEA or testosterone, whatever you think is appropriate, and they'll just do great, right? Just great. But other people, oh my gosh, you move it around like 0.1. It's like the wheels come off. So it's very, if you're listening to this, realize that you need to understand that you're going to need to potentially work with somebody carefully to get this dialed in. It's not like, oh, just slap a patch on me and I'll be good. It really does take some fine tuning depending on who you are and how your body works.
Yeah. And I do find it's very correlated to their gut microbiome. I find it's correlated to how their liver is able to, if they've got the genetics or any type of mutation that's not allowing them to metabolize hormones properly. And it also has a lot to do with how they're managing stress and sleep. And so as I talked about, we have these higher, more sensitive people, it's either a genetic play or it's just poor microbiome management. And so that's why, it's really a comprehensive program. Yep. You don't just slap hormones on women and just send them out the door. I watched that happen to my mom and it wasn't the solution. It really needs to be a comprehensive approach.
Agreed. No, I think that's exactly right. It's a very productive avenue to go down, but it also is one that has its twists and turns, and you really need to go into it with your eyes wide open and work with somebody that actually, can navigate the twists and turns with you. So,
yeah,
beautiful. Well, Mariza, thank you so much for being with us. Really enjoyed the conversation.
Me too. Thank you.
Thank you for listening to this week's episode of the Gladden Longevity Podcast. If you would like more information on what we've discussed or other topics, please reference the show notes or go to GladdenLongevityPodcast.com. You can also find us on Instagram, Facebook, and Twitter by searching Gladden Longevity. If you've enjoyed this podcast, please subscribe to get future episodes delivered to you and share our podcast or this episode with someone in your life that you may find benefit. Thank you for listening. We'll be back next week with another exciting episode. The Gladden Longevity Podcast is provided for informational purposes only. It does not constitute medical advice. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of a physician or other qualified health provider with any questions you may have regarding a medical condition. The use of any information and materials linked to this podcast is at the listener's own risk.